Welcome to The Digital Patient, where we discuss the latest advancements in digital patient engagement and share stories from the front lines. I'm your host, Alan Sardana, and with me as always is SeamlessMD CEO, Dr. Joshua Liu. Today, we're joined by our very special guest, Dr. Michael Radtke. Dr. Radtke serves as the Associate Chief Medical Information Officer at Intermountain Health in Colorado, overseeing informatics related to physicians and ambulatory workflows. He's a board-certified clinical informaticist with over 13 years of experience in leading various initiatives such as ambulatory EHR deployments, telemedicine service line deployment, physician well-being programs, and patient portal rollouts. Dr. Radtke, Mike, welcome to the show.
Thank you. Happy to be here.
Amazing. So, Mike, you spent the last decade or so really bridging the gap between the clinical world and technology. And coming from the clinical world yourself as an immunologist, to start the conversation, could you tell us, how did you first get involved in the world of health IT and digital health?
Well, like many in my situation, I've been a computer geek for as long as I can remember. But I really wanted to leverage technology to improve experiences. So right out of the gate, I was looking for projects to get involved in. It's actually kind of a funny story because I approached our CMO for the first place I was working at outside of Chicago. And I said, Neil, I really want to get involved in some leadership related to IT. What can I do? And he said, well, Mike, my suggestion to all new leaders is this: find something that is such a mess that you can't mess it up. So any little thing you do will make you look like a rock star. And our patient portal was a definite mess at the time. So I took over the re-rollout of our MyChart patient portal, and we had significant improvement, both in terms of active users, sign-on rates, et cetera. And that led to a variety of other projects like telehealth initiatives and other things that maybe today seem a little bit like table stakes, but at the time was relatively new. And just gave me a taste for the thing and kept going from there.
So, and actually, Mike, do you mind unpacking that a bit more? I was wondering
Sure.
Back then, what was the low-hanging fruit you saw with the portal that you identified and made changes on?
So we were still fairly, I would say, a little behind the curve, to be honest. So the low-hanging fruit with things like improving the messaging between providers and patients. It was things like getting online bill pay and online release of information up and running. Once we got that stuff done, that's when we started looking at some of the cooler things that we could potentially do, like what education can we push out to patients and how can we better engage them.
And what was your process for determining what the biggest areas for improvement were? Like, were you spending a lot of time doing discovery with clinicians? Were you, I guess, talking to random patients? How did you end up gathering that information?
Yeah. So it's really important, that piece, because I think there's a trap that a lot of groups fall into where let's turn it on either just because it's available or because the folks down the street do it, and you don't really get much value out of those. So we really looked at a few different things. One was presentations that colleagues had done at Epic to see what was working and what really got them a lot of value. It was also analyzing what pain points our patients and our providers were feeling. Patients really wanted more of that self-service component, especially back then. That was kind of a big thing. Hey, I can schedule my appointment online. That's fantastic. Again, today it seems like, of course you can. Why not? But at the time, that was really a big change for them. Or being able to have better communication with their providers. I mean, nobody likes leaving a voicemail or playing the phone tag game. They really enjoyed that communication. And that sort of thing, I think, was what really drove a better engaged patient.
I think you actually mentioned a really great point, and I see this challenge with not just health systems, but even in our own organization as a company, where it's so easy to fall into the trap of what are other similar organizations doing, and let's just do that. But to your point, if you don't actually step back and say, well, is this actually a problem for us, for our patients, our providers, then you might implement something that doesn't actually create value because you just didn't have the same problems other folks did. So that makes a ton of sense. One of the other topics that, and sorry for going off agenda too much, but one of the other topics Al and I were discussing before this was around how much time you spend as a CMIO between clinical and IT. I think we've heard some folks say, well, you got to be doing at least 20% clinical so that you still have that frontline experience. How do you think about how much time you spend in each vertical?
Super common question. And I get this asked of me a ton, especially for budding informaticists kind of making a career path choice. And I think there's pros and cons either way. Having a small component of clinical time obviously gives you some street cred and allows you to understand what the active practicing physician is feeling. It does take away from your time doing the bigger strategic things. And so I think it has to be a balance that each person and each individual situation has to take. I personally don't have any clinical time, partly because as an allergist, it would be really hard for me to provide a good service to my patients if I'm only working a half day a week. Others who have more of a shift-based thing, say a hospitalist or an ER doc, I think it's a little bit easier to do that sort of intermittent work. But I think if you don't have clinical time, making sure you have the right team around you, that you're spending a lot of time listening to your clinicians, you can get a lot of that same input. I mean, even if you are still practicing, say as an ER doc, that still doesn't help you understand what a primary care doc in the ambulatory clinic is experiencing. It gives you some experience, but you still need to leverage your team and your ears in order to understand what's really going on elsewhere.
Yeah, totally makes sense. And now that we're on the topic of physicians and listening to the team, I'm curious. This was a writing that you had posted a little while back about clinician burnout, and in particular how dissatisfaction with the EHR can contribute to burnout. I think I read somewhere like 8 hours of time per day or per week is spent in the EHR just trying to configure all the notes and everything, which is insane to hear about. But my question for you, Mike, is actually, what can health systems do to avoid this kind of clinician burnout as it relates to the EHR moving forward? I know you spend a lot of work kind of solving this issue. What are your thoughts here?
Yeah, I think you're referring to that class survey result that showed a provider who is dissatisfied with his or her EHR is 3 times as likely to leave the organization than one who is satisfied. And that's a tricky one because there's a lot that goes into that. That being said, some of the data that's come out over the years has shown that some key things really do drive provider satisfaction with their EHR. One of them is trust and collaboration with IT. And I think this is where informatics really plays a huge role, because it is getting docs and other providers, nurses too, involved in the planning, the implementation, and the use cases for various IT systems. And it's really means that we focus more on that value prop that we were talking about earlier, so that if we're going to put something in, it's going to give us some return, whether that's making your life better, whether that's being something that's better for patients, whether it's improving our revenue, whatever. But there's something that we're getting out of this of tangible value, and you have a voice in that. It's really getting at the point that a lot of burnout is coming from this sense of hopelessness almost, in that providers don't feel they have as much control over what happens to their day-to-day as they might have back in the past.
And Mike, I think for a lot of initiatives, we've seen having champions is really important. So, in many ways, you're the champion for informatics for the whole organization. I was wondering, is part of the strategy that you try to find champions in each department or major service line, or is it a different approach to getting frontline buy-in?
No, absolutely. In fact, I think that's part of why one of the other factors that class found that leads to satisfaction, at least for Epic institutions, is to have a physician builder in a specialty. And other EHRs have similar concepts, but the idea being you need somebody who really is that frontline user that spends most of their time in clinical work, but maybe a little bit of time in informatics, whether that's actually building or being a champion, a bidirectional communication conduit, all of the above. Going to change depending on the person and the specialty. But that's really where you have your ability to reach into these specialties and understand what's going on with them, as well as to help have somebody who's a trusted messenger when a change comes through. Whereas, as a CMIO or an ACMIO for a large organization, there's no way you could get out and do that for each and every specialty out there.
It makes a ton of sense. You mentioned a few minutes ago the importance of giving clinicians confidence in digital and IT. And we definitely want to get to some of the neat work you're doing with AI and NLP in a second. But before we do that, I'm sure you've seen a lot of maybe mistrust or a lack of understanding of AI in general and how that can affect healthcare. I was curious, is there anything that you found to work to get clinicians' confidence in AI, in models that maybe they don't fully understand, like what data is going to the model, how is it being processed? It's kind of a black box. Like any ways you approach building confidence when it comes to implementing AI in the healthcare environment?
I mean, it's two pieces. It's transparency so that they know what the thing is doing, and it's understanding how it fits into the workflow. I think, unfortunately, there has been a rush to get a lot of models and a lot of AI in place, and we're kind of breaking one of the fundamental pieces of any clinical decision support, and that is it needs to be following like the 5 rights, for example. Making sure that it's not just showing me some risk percentage. Okay, well, what do I do with that now? It's figuring out how do I leverage that information to drive a workflow that's going to materially change something, whatever that something is, whether it be mortality, morbidity, length of stay, et cetera, but something that actually is going to drive some clinical important piece. When you show clinicians that and say, this thing we're implementing, this thing we're asking you to do is going to have significant impact, positive impact on your patients or your life, they get behind it. When it comes across as just, hey, this is something read about that somebody else was doing, or hey, this seems kind of cool, or hey, intuitively we think this is going to work, but we have no idea, most docs won't get behind that. I mean, we're trained from the beginning, right? Follow the data, follow the evidence. And when we don't have that evidence, naturally people get skeptical.
So it sounds like in many ways, the so what is really important. So to your point, you can have all the great, predictive insight in the world about a certain, metric or data point. But if your clinicians are saying, okay, well, it's great that you show this, risk prediction on the dashboard, but if it doesn't actually change my management, like, why are you showing this to me? I don't care about AI. So it sounds like it's really important to understand, like, what is the so what, so I can create value for my patients. And if you make that connection, it sounds like you can get some really good buy-in.
Absolutely.
So actually, in line with that, Mike, let's dig in a little bit into that NLP AI initiative that you've started. Essentially, one of the strategies at Intermountain is to work with Microsoft and Nuance to leverage this new technologies, AI, voice recognition, and NLP model to streamline the time that clinicians are spending in the documentation portion of the EHR. So what's the genesis for that story? How did you come to find out about the technology, and what are some of the major learnings you've had so far?
Yeah, so we've obviously been using front-end voice recognition for years and have had a long-standing relationship with Nuance. Craig Richardville, our CIO, is really forward-thinking as far as trying to partner with vendors, especially when early on in products, to help innovate and drive where the product's going to go. So he really spearheaded getting our Dragon Ambient experience, or DAX, pilot up and running. The idea being that if we can leverage AI to take away a task, we can free up physicians to do other things. I mean, I've never heard a physician say, yes, I love documenting. This is a value-added thing to my day. And so if we can say, let's have an AI that's just going to listen to your conversation and know what you're talking about, knowing who's speaking when and in what context, understanding what the exam is like based on your description and understanding what the plan is, and then generate that note with minimal physician interaction, then what we're really doing is what AI should be doing, taking that task off the doc's plate so the doc can devote more mental energy and attention to the human being sitting in front of them. That's, I think, the other piece of this physician burnout crisis. It's not just the fact that I have no control over my day, but also that I went into this because I enjoy human interactions. I enjoy when someone comes to me asking for help, being present with them and engaging with them, not busy trying to type a note and make sure I capture everything the way that I need to. So our initial learnings have been that this tool, like any other tool for a subset of users, is absolutely fantastic. I mean, I got an email from one a couple of weeks ago that said, so I just tried this DAX. I'm going home today on time, and I don't have a single note to write. I don't know how I practiced without this before. Now, we've only had subjective feedback so far, and so the next step is to have a larger scale phase where we're going to have a fairly large cohort of providers using DAX compared to a fairly large cohort of matched providers that aren't. So we can follow some more of the hard metrics, things like number of visits, what's our turnaround time on notes, days of closure, that sort of thing, and see where we can actually move the needle in a more quantitative way. But qualitatively, making the docs happier and helping them engage in patients interactions better, I think provides an ROI on its own. I mean, think how expensive it is to replace a doc, right? I mean, it doesn't take much to recoup that cost.
I mean, I guess in today's world, especially since the pandemic, when clinicians are so stressed and overworked, anything you can do to improve that day-to-day experience is going to be a really critical tool for not just satisfaction, but retention of staff. I was wondering, and maybe it's too early to tell, but in terms of the level of personalization that's happening with the learning of the model on a per clinician basis, like are you seeing so far where it's actually learning certain phrases or mannerisms that's specific to clinicians, so that way it's accurate to each clinician, or is it more of a generalized model that's picking up on the high level concepts that most clinicians would speak to in that conversation?
And that's really where we're getting at the fact that we're partnering with them in an early phase of this. I mean, right now, and this is not just Nuance, other groups that are doing the same sort of thing. It goes to an AI to generate a note, but there's still a human intervention to review the note compared to the recording to make sure that it matches up. So it's still learning. But from what I hear from Nuance, the AI is learning very, very fast. In the same way that cloud-based voice recognition learned very, very fast. You know, I mean, we had that switch, it was a dramatic change in reliability and accuracy because you could start pooling large quantities of data. So as more and more groups and more docs use DAX, the AI is getting smarter and smarter.
I think it's fascinating as well because it's using, you know, readily available technology that's around us. I think I read it at Intermountain, they're using either a tablet or a phone in the room to actually capture it. And it could be any type of device with a microphone, which is just really awesome. So actually, I did want to shift gears a little bit, Mike. You've actually worked on many different EHRs over your career. At this point, I know you were working on Cerner when you were at Banner, and then Epic now at Intermountain, and I think you also worked at Epic as well. And so for clinical IT leaders who are having to move systems and possibly shift to a different EHR system, what advice would you have for them on how to successfully navigate a transition like that?
I think it's not unlike any other large change. It really starts with listening and understanding where your folks are coming from, making sure that they know that they are being heard, and lining that with setting realistic expectations. I've seen situations where folks promise the moon with any kind of change or upgrade, and it's not going to be like that, especially not on day one. I mean, I've never seen an implementation of any system that goes completely off without a hitch on day one. There's always something, right? So you have to set expectations that, hey, this is going to be bumpy in the beginning, but we're all learning together. And then that has to be coupled with the promise of continued improvement. It's not going to be perfect in the beginning, but we're going to keep working at it so that we can continue to make it better as I'm listening to your feedback. Does that mean everybody gets what they want? You can't do that, right? It's a system. We have to balance things, but we want to make sure that when someone has a genuine problem that we can fix, we fix it. And if it's something we cannot change, we give them a good reason why, and we help them figure out a way around it. But it's really being present and focusing on that listening and continuing improvement that I think is really what sets apart the successful from the unsuccessful.
I think that makes a lot of sense. I think it ties in really nicely to the concept of failing while innovating. And so curious to get your thoughts on, you know, implementing any type of innovation involves risk. What's your view on the relationship between those two, failure and innovation?
I mean, first, you want to make sure that you've leveraged the community around you. I mean, we're lucky in that Informatics is a fairly open and collaborative community. And so if you're going to do something, make sure if somebody else has done it first, you don't replicate their mistakes. But beyond that, you have to fail, and you have to fail fast so that you can then iteratively improve. Unfortunately, in healthcare, I think there's still a tendency to want to approach things from the waterfall method, try to get it as perfect as we possibly can, and not recognizing the fact that perfection's a moving target in these things. Better to get something and really analyze it, test how it's doing, and then rapidly, iteratively change. That's the only way that innovation is going to work. I mean, it's one of the reasons Epic moved from its 18-month release cycle to its 3-month release cycle so that they can more rapidly make changes. And we do the same thing, although I think it's still a struggle with some to let go some of that target for perfection and just say, let's get what our minimal viable product is out the door, making sure it's safe, of course, and then monitor it. And I think that's the other piece too, is you really have to have a strong focus on metrics. You have to know ahead of time, what am I going to measure to see if I'm successful or not? And why does that measurement matter? Also, don't be too crazy with the measures. If you're measuring 15 things for every product, or every project, it's going to be a little hard really to keep track of that. Find the real key metrics that are important to your organization, to your docs, to whoever, so that you can really identify whether you're moving the needle or not.
I love that thought about making sure failure is something that is open and communicated. It reminds me of this concept I was reading about the other day. We talk a lot about, let's call it piloting new things, but I heard this term of the anti-pilot, where the idea is you start turning things off and you see if anyone notices. So for example, it may not be a technical thing. It could be, you know what, let's stop having this specific weekly meeting, or let's stop doing this task that we're frustrated with, and see if it changes the outcome, see if people remember that they used to do it. And if the outcome is the same and satisfaction is the same, well, maybe it was fine to sunset this. So I don't know if that sort of concept has ever happened in healthcare regularly, but it gave me a lot of food for thought.
There's been a number of reports of groups doing that with clinical alerts. They just say, we've got all these alerts that are firing, nobody's doing anything with them, let's just shut some of them off. And then they follow either clinical outcomes or satisfaction. They find that, yeah, clinical outcomes don't change if we don't keep badgering people about silly things.
Go figure. So a couple of months ago, you shared an article on LinkedIn about this concept of CMIO 3.0 and how that role has evolved. So in the past, it was first implementing EHRs, then it was optimizing EHRs, and now going forward to, and you phrase it as organizational strategy, pop health planning, and patient engagement. Could you share more on how you see the CMIO role evolving over the next 5 to 10 years?
Yeah, I mean, the strategy is the sort of cornerstone to it all. It's not about the tactics of let's get something deployed and then let's try to optimize it. It's more, where do we want to go next as far as pain points we want to address or reacting to a shifting healthcare landscape. Obviously, COVID is a great example of this, how we had to really quickly change our entire healthcare delivery model because everything was shut down. And it's a matter of recognizing sort of where the puck's going to go and skate to that sort of thing. You can't do that sort of strategic thinking if you're busy running around helping folks with their optimization. Not to say that isn't important work. I mean, you still have implementations, you still have optimizations, you still have physician well-being to think about. But it's assembled a team so that you can delegate some of those things and really work more closely with clinical leaders about where do you want to go next. We see this kind of bear out a lot whenever there's new projects that are being considered. If you don't have informatics as a part of that initial conversation, you may not build a pathway that can be well supported, or you may miss out on some great opportunities because there are other things that can be done that'll even streamline it further. So I think it's really about being part of that initial conversation so that we can craft the best possible product and also adjust as need be, like we were talking about it a minute ago, whether it be an informatics thing that needs to support a different workflow, or maybe there's an assumption that was made that wasn't quite right and we need to change, whatever it may be, but being part of the iterative process.
Yeah, I think a common thread through this conversation is just being able to listen, and listen to what clinicians are saying and look at the data and measure the right data points.
And recognizing that healthcare is changing, right? And at some point, who knows when this is going to happen, but at some point, all of us are no longer going to be beholden to trying to get as many patients in the door as possible or as many surgeries done per week as possible. It's going to really be focusing more on how do we manage chronic conditions? How do we keep people healthy, right? And that sort of shift is definitely going to require a lot of technology solutions built differently than some of the technology solutions we have now, right? It's very different to figure out how am I going to help drive better behavior, healthier behavior, versus how do I make it easy for a patient to schedule an appointment and get in to see me?
Right.
Right. I mean, in the future, maybe more about how do we make it easier for you to see the patient, and that might not be in the, I mean, if we're already seeing it's not always in the four walls of the clinic or the hospital.
Absolutely. Absolutely.
That's a good point, actually. I'll jump in there, Josh. It's a good point. Mike, you're one of the leaders on the Intermountain SeamlessMD partnership, where your organization is now providing digital care journeys for patients who are going through an episode of care. Maybe it's a surgery or a chronic condition. So in order to engage and monitor patients outside the four walls of the hospital, like Josh mentioned, pre and post surgery, for instance, curious, could you share a little bit about your overall vision for, how does the digital patient experience and where does the partnership with SeamlessMD fit within the overall patient experience?
So there's a term that we used to use when I was still part of the advocate system called the tyranny of the moment. And what ends up happening is you have a visit with a patient, 15, 20 minutes, and you go over all kinds of great behavioral strategies or whatever they're supposed to do, and for example, recovery from surgery. But then they go home and they're combated left and right with decisions they have to make related to their healthcare. And it becomes really hard because there's a ton of noise, there's a kind of competing things going on for people to either make the wrong choice or completely forget about things like, oops, I'm supposed to do PT 3 times a day and I completely forgot about it. Totally normal. That's just the human condition. And so using digital engagement, digital coaches, that sort of thing is a way to help nudge patients, sometimes gently, sometimes not so gently, so that they can make better decisions and we can drive better behavior. I think that is one of the huge next steps in all of this, as long as it's staying relevant. And I think that's really where things like SeamlessMD are really powerful, because it can be relevant to what's going on with me, what do I need to do, responsive to what's going on, as opposed to here's just a 15-page information packet on what it is to have hip replacement, for example.
I think what strikes me, Mike, is that in medicine, we're so good at coming up with better and better protocols and evidence-based care pathways and care plans and new treatments, medications. But the one piece that we've really struggled with historically has been, how do we actually get patients to be compliant with these better and better steps and protocols and instructions? So I think you made a great point about how it's one thing to know the right thing to do. It's another to how do you actually engage patients to stay on track with good practice and good care. And definitely, I think digital is a way that we can help bridge that gap. That makes a lot of sense.
There's data too, by the way. There's data that show outcomes do improve as the patient gets more engaged. I mean, I think there's a paper that I think was in Health Affairs a couple of years ago that showed patients who were highly engaged patients who were poorly engaged were twice as likely to be readmitted within 30 days than patients who were highly engaged. And there's tons of other evidence along those lines. The trick is it has to be the right kind of intervention. Just like you can't do a study that says, hey, does a pill help blood pressure? You have to have something that's as targeted, relevant, and specific intervention.
It's such a great point. I remember, this is probably almost 10 years ago. So, now hospital at home is a very, very common concept, but, 10 years ago, there's this concept of the virtual ward that came out, and it was basically giving hospital level care in the home, not so much remote monitoring, more just visiting the home with physicians and other providers. And there were some RCTs done locally here where it didn't see an improvement in 30-day readmissions. That was the primary metric. I think some studies in other countries or other regions did find benefit, but basically mixed results. And I think part of the conversation was, logically, it should make sense that a hospital at home or virtual ward should work. But I think there were questions around, did we stratify the patients properly? Because if we segment the data, there were certain very high risk patients where the virtual ward concept was very effective. There were certain low risk patients where it did not make an impact on outcome. But when we put all that data together in one chunk and gave give every patient the same intervention, it looks like it doesn't work, but we just weren't directing the right intervention at the right times. I think you make a great point that, we can't assume that it's a one size fits all approach to care delivery. And the data is going to show, well, which populations do benefit more, which ones are going to benefit less. And I think we've even seen that from a digital point of view. There are some patients who engage with mobile, some who need web, some text. It definitely varies even from a digital perspective.
Yep. I remember there was a survey that looked at willingness to engage with a mental health app, and even just looking at age distribution, that the younger were more willing to engage with an app, the older preferred to do like a video visit, for example, with the provider. And so I agree with you, stratifying that makes a whole lot more sense than just saying, here's the one thing, and let's hope it works for folks.
Mm-hmm. Yeah, exactly. Now, Mike, you mentioned earlier in the conversation that, Craig Richardville had the foresight to partner with a lot of early companies and vendors to build the partnership over time. And I think, a lot of health systems, or at least the well-resourced ones, are going the route of let's build everything in-house. But you really took the opposite stance and recognized the value in a strategic partnership with different vendors, solving complex problems like digital care journeys and voice recognition, NLP, for different innovative solutions. So the question that I have is, what makes a great partner?
Yeah, it's something that I think is evolving, and COVID, I think, helped spur that evolution really well, because we've had to move quickly, and the only way you can do that is if you have a vendor that's a partner too. It's really, it's a big component of trust. It's a big component of being transparent about what's possible, what isn't possible, what's coming, what isn't coming, knowing full well. And I think this is where Craig has really sort of set a good mindset for this. Roadmaps for development are not promises. There's things that sometimes change or get in the way, but knowing that it's always transparent, knowing that your voice is being heard as a customer, not thinking that I'm going to get everything that I ask for, but knowing that my feedback is valued, and that I have an opportunity to be an early adopter if I choose on things that are coming, really makes it feel more like I'm helping in that design and development process. I'm helping guide where something goes. And I think that's a big piece of that partnership. It also comes from our side too, the idea that, hey, I'm making a commitment to a particular organization because I value what they're doing and how they treat me. And I think it's going to evolve over time even more, but it's just too integrated, these kinds of technologies, to be kind of treating it as a keep it at arm's length kind of thing. Patients' lives are on the line here, and so we all have to really work very closely together to make sure we're providing the best that we can and changing when it's not meeting the mark.
That's a really great point you make there, Mike. I think one of the things that we've really taken to heart is, there are some other industries where you can have an MVP, a viable product. You can't do that in healthcare, right? When you're talking about patient safety, you cannot just throw an MVP into a complicated clinical environment, and if it goes wrong, oops, that's okay. No, that doesn't work in healthcare. You have to be really thoughtful about these interventions. And I think unless you've been in that environment, you sometimes don't understand that, we all like to move as quickly as possible, but unlike at Facebook where you can move fast and break things, you really don't want to break things in healthcare. You want to move fast, and then you want to make sure things don't break, that they work. So I think that's a really great point you made there about safety.
Yeah, I think there's a sort of understanding where the guidelines or guide posts are, so that this is okay to break, but this is not okay to break, and knowing where that area is where you can really drive the innovation.
Yeah, an MVSP, like a minimum viable safe product, and still able to innovate.
In my mind, an MVP in healthcare has to be safe to begin with, right?
Right.
But
exactly.
But yeah, and it has to provide some incremental value too.
Mm-hmm. Totally. So actually, while we're on the topic of innovating and integrations, I'm sure IT receives a ton of requests to integrate the EHR with all these different solutions. What's your mental framework for deciding how to prioritize the integrations?
So we usually first ask the question of, can we do it with our existing existing portfolio. Sometimes it's can we do it within the HR, but sometimes it's can we do it with an existing vendor. Then I think the next step is really what is the impact? And impact can be defined differently depending on what you're talking about. Sometimes it's a matter of how many patients are impacted. Sometimes it's a matter of how many docs are impacted. Sometimes it's a revenue thing. But really, is this something that is going to have a large scale impact or not? That doesn't mean small scale impact things don't happen. It just means that in a world of limited resources, we have to go with the things that provide the most value. It also needs to connect with some strategic initiative. It's just, again, with resources the way they are, you can't just go through every pet project that's out there. You need to make sure that it's something that aligns with what the organization is trying to do. And part of that is making sure there's a clinical champion. There has to be somebody who's actually providing care to patients who cares about this thing. If there isn't, it's not going to happen anyway. So no matter what you do with the integration, it's going to die on the vine. And then you balance it all out with the opportunity cost. If I do this, that means I can't do that. And do I think this is more important than that? And that's based on all the previous information.
It's a really great point you made there, Mike, where it's just because you're saying no, it doesn't mean it's a bad idea. It doesn't mean that it won't make sense later, but it's your point from a practical point of view. It's, is there a clinical champion like today for this, or does it actually align with a strategic priority for the organization right now? Because if the answer is no to all those things, then it's like, okay, well, even if we try to do it, it won't be successful today. So we shouldn't be putting resources there, but it's not a no forever, probably. It's still often a great idea. It's just not yet here. And I think even I've seen it too, where, I think vendors often misunderstand that, where, just because someone is saying no, now's the health system, they're not saying the innovation or the idea is necessarily bad. It's just, it really might not be successful here right now. And that's okay. Don't take it personally, right? And it's probably true for clinical champions who want something now, but you just can't practically make it work today. But I guess if that's communicated well, then I think folks will understand, and they'll be waiting for their turn and waiting happily too. And also, I think that they realize that you're trying to support them to be successful. So if they get that perspective, I think generally they're probably okay. But I guess if it's not communicated well, people can totally misunderstand why they're getting pushback from IT and informatics and all that.
Comes back to that same concept of making sure they feel heard.
Mm-hmm.
Yeah,
absolutely.
Also love the saying, "Let it die on the vine." I thought that was that was a great. Never heard that before. I love it.
Oh, I've seen so many situations where you've got some product or whatever and nobody's using it.
Totally.
It's like, why did we spend the time and resources to get it put into place?
Yeah, I imagine. And actually, on that note, Mike, today after COVID, there's this explosion of patient-facing digital health and all these new innovations. What innovations from a technology standpoint most excite you today?
Well, I think the concept of digital coaches is number one, because really there's so much benefit to helping guide patients in their day-to-day lives and helping get those great protocols that Josh, you were mentioning actually into practice. I mean, what was the data? I think something like 60% of people who were started on an SSRI for their depression aren't taking it a month later, which it takes 6 weeks to kick in. Mm-hmm. So you haven't even given it a full shot yet, right? So being able to influence that behavior in a way that works for a patient, I think is tremendously valuable. I think a lot of the remote monitoring and patient entered data is going to also be really critical, just because we're going to continually need to have more data than just what we get in that 15-minute visit. And I think it relates to the digital coach too. If you have a digital engagement tool for CHF, you're going to need to get some data points along the way to help with that, for example. And then another piece is really the burgeoning omni-channel outreach. I like a phone call, I like a text, I like to go to the website. Give me the same experience no matter what avenue I'm using, and as I move between the avenues, don't make me start all over again. It's a little bit more of a patient experience thing, not necessarily a clinical thing, but that being said, If patients have bad experiences, they're going to resist engaging with you. And that might mean that there's care that they need that they won't get. I think COVID was a great example of how that needed to work, because we needed to change a lot of our channel approaches, again, based on the fact that we just couldn't get people in.
Yeah.
I love that. Actually, it reminds me when I was more clinically focused as a patient, it was always frustrating to repeat your clinical history to every single clinician that you would meet in a single evening. Has that, I've been out of the loop at the front line for many years now. Has that improved at all, or is that still happening usually?
It is improving. One of our initiatives that we've been undergoing this last couple of years is our pitch the paper initiative, so that we eliminate these paper intake forms and instead leverage digital tools. Partly because of that. I mean, you get a blank piece of paper and say, fill in your medical history, even though you've already done this at 3 other offices in the same institution, drives people nuts. Of course, the next step is going to be, well, I told institution A that, why does institution B not have that information? And the interoperability is coming along, but it's still not where it needs to be. I do think it's better than it was, 5-10 years ago, but it's not where it needs to be yet.
Yeah.
Fair enough.
Makes sense. Well, CMIO 3.0, that's carried on the next form of interoperability and taking it further with all these new innovations. Awesome. Well, Mike, let's shift over to what we call the Fast 5 lightning round. This is basically just 5 questions to get to know you better for our audience. First question we have is, what is your favorite book or book you've gifted the most?
This is constantly changing, but right now it's Dune. I read that 30 years ago, and I reread it after watching the recent movie, and absolutely favorite science fiction.
Yeah.
It's on my to watch list.
Oh, it's phenomenal.
Yeah. It was really, really great. I wonder how many parts they're going to have. Maybe a 2-part, 3-part. I don't know. But
yeah, I didn't get very far into the book.
No, that's right. Yes. Awesome. Okay. Question 2. This one's specifically for you, but what is your favorite Star Wars film? And in brackets, why is it Empire?
Because it's Empire. I mean, it's clearly the best written of the bunch. Although I do think Rogue One gives it a good run for its money. I really like Rogue One. It's Star Wars. I'll watch it.
Yeah. Awesome. Question 3, would you rather have super strength, super speed, or the ability to read people's minds?
Definitely not reading minds, because that would be creepy. I'd probably say super strength. I've got 2 big dogs, one of whom snuck in here while we were talking. So lifting them up, I need some strength.
That's great. Question 4, what is something in healthcare you believe that others might find insane?
Just one, huh? How much faxing we still do.
Oh yeah.
Definitely.
Yeah.
Drives me insane.
Well, someone's got to keep that industry in business. So why not the largest industries in the world, healthcare?
I guess. I don't know.
Great. Last question, Mike. This is a pandemic kind of lockdown related question, but what is one hobby or activity you've gotten into since the beginning of the pandemic?
Yeah, it's not a new one, but I picked up guitar again.
Oh, sweet. Nice. Any particular guitar, like acoustic, classical, or?
No, I mostly electric. I picked up a beautiful used Fender at one of the local shops here. That's just amazing. And so I've been playing a lot of classic rock.
Nice.
And the heavier recent stuff too.
A
lot of distortion. It's a lot of fun.
Yeah, that's great. Well, Mike, thanks so much for joining the show today. We're coming up to the hour, so being mindful of your time and everyone's time listening. Thank you so much for coming on and sharing a ton of wisdom with our audience in terms of where the industry is shifting from CMIO 2.0 to 3.0, and how you have to really listen to everyone around you, including the clinicians, the patient, executives, leadership, everyone, to understand where the innovation should go and where to prioritize things. Everyone, that's a wrap for this episode of The Digital Patient, hosted by SeamlessMD. Follow us on Twitter at SeamlessMD. If you like the podcast and want to learn more, visit www.seamless.md. Mike, thanks so much for joining again.
Thank you, guys. Thanks for having me.
Thanks, Mike.